A very good evening to one and all present over here. Now, for today, myself, Dr. Neha Singh Mandade, I'm a neurophysiotherapist and associate professor at MIT College of Physiotherapy, Latur. And on behalf of Indian Association of Physiotherapists digital media team, I'm here to host this today's evening webinar. And with us that we have as a resource person, Dr. Nirmal Surya sir and Dr. Dorcas Gandhi ma'am. And to take away this entire session, we have our moderators with us, Dr. Dharam sir and Dr. John. To begin with, I would like to introduce you briefly about IAP and IAP Digital Media Team. The Indian Association of Physiotherapists is the oldest and largest association which represents the physiotherapists in India since the year 1955. The IAP digital media team consists of a group of physiotherapists who handle the Zoom platform, webinar live streaming, and IAP profiles on the social medias, that is Instagram, Facebook, Twitter, LinkedIn, YouTube, etc. We may also follow the links we will share shortly on the chat box for our IP profile so that you stay updated with the activities and receive notifications for the CMEs, the events, the webinars that gets conducted under this platform. And also you may subscribe to our IAP YouTube channel where we have separate sections of different categories of orthopedics, neurology, cardiopulmonary, pediatrics, sports fitness, and women's health and cancer rehab as well. So the social media links would also be shared shortly in the chat box. And for starting with the session, I would hand over to Dr. Dharam sir as moderator to take away this session. Thank you, sir. Over to you.
Thank you. Thank you, Dr. Neha. And very good evening, everyone. It's our great pleasure to welcome the esteemed panelist on behalf of Indian Association of Physiotherapists and IAP Neurology Subgroup to this expert interview series. And we are truly honored to be joined today with the two distinguished leaders in neurorehabilitation, none other than Dr. Nirmal Surya sir and Dr. Dorcas Gandhi, and our moderator, Dr. John Solomon here. So thank you all for gracious sharing your time here and expertise with us to this platform. Neurorehabilitation in Asia Pacific, reason why we are gathering here and discussing on that, it stand at a very, very critical juncture, and where growing clinical demand, interest, and with the policy gap, it intersects with the policy gap, workforce challenges, and rapid technological development. So today's conversation will be focused on future of neurorehabilitation in Asia Pacific region, with particular emphasis on how the policy is changing, how clinical practice in this particular field is taking place, how technologies is emerging, and education is in place. So how these pillars can come together and deliver equitable patient-centric care. So I'm very confident with today's dialogue, we will learn so many things, and there'll be expert will be sharing valuable insight for clinician, educator, and students and policymaker too. So with that, I now invite our moderator, Dr. John Solomon, to take over and introduce our panelists and start the expert discussion. At the end of discussion, we will be taking the questions from audience. So Dr. John, you may proceed, please.
Thank you, Dr. Dharam. It's a pleasure for working together in organizing this session on behalf of the neurology subsection of IAP. And it is my honor to introduce the two eminent leaders for this interview session. So our first panelist is Dr. Nirmal Surya. He is the chairman of Surya Neuro Center, founder, trustee, and chairman of Epilepsy Foundation India. He is the president of Indian Federation of Neurorehabilitation, and he is also the Secretary General of World Federation of Neurorehabilitation. He was a member at large presidency of WFNR. He is the Regional Vice President for WFNR, a chair for Developing World Forum of Special Interest Group of WFNR. He is also the President of Asian Ocean Society of Neurorehabilitation. He had been the past President of Indian Academy of Neurology as well as Indian Stroke Association. I have just briefly introduced about the various prestigious positions he has held, but beyond that, he has been a very hard-working neurologist who has established himself as a great clinician, educationalist, as well as researcher. He has multiple papers to his credit. He is a very dynamic personality, a go-getter, a multitasker, and an exceptional leader, global leader who has brought Indian perspective. A very warm welcome to you, sir.
Thank you very much. Namaste.
The second leader that we have here is Dr. Dorcas Gandhi, who has specialized in neurophysiotherapy. She is the Vice Principal and Professor at College of Physiotherapy of CMC Ludhiana. She is also a Research Fellow and Telerehabilitation Consultant, Department of Neurology, CMC Ludhiana. She holds honorary Senior Research Fellow of University of Central Lancashire, England. She is a future stroke leader of Cohort 3 of World Stroke Organization. She is presently pursuing her PhD at Manipal College of Health Professions, Mahe, Manipal. Her work is around developing clinical practice guidelines for stroke rehabilitation in India. She is also a Lancet Commission member of Lancet Commission of Neurorehabilitation, member of World Rehabilitation Alliance, and she is also the founding member of the Global Consortium of Stroke Rehabilitation. And she has extensive research experience is well listed out. And she's someone who is very passionate about neurophysiotherapy and in delivering evidence-based practice, especially in the low resource setting. And her work, PhD work of CPG has been instrumental in developing the clinical practice guidelines of IAP as well. So with these few words, welcome Dr. Dorcas.
Thank you so much, sir. Thank you.
So to begin with, I'll start our questions based on the certain larger perspective. So I first would like to ask the question to Dr. Nirmal Surya. So now, as you know, Asia Pacific region is one of the largest region in the globe to face burden of neurological condition. And from a regional perspective, how do you see neurorehabilitation evolving in Asia Pacific region over the next decade, especially in these countries where low middle income countries are more?
Thank you, John. You rightly pointed out that the region which we are living represent nearly 60 to 65% population of the world, and India being the largest in population, and proportionately so is the neurodisability. If we talk only about India, the neurodisability is 2.2%. And if you look at globally, it is around 3%. So there is a definite issue related to the neurological problem. And even if we talk about the rehabilitation available to our Indian population, not more than 10 to 25% people are getting the neurorehabilitation of this neurological disability. Now, Asia Pacific region has a diversity. There are countries which are having the best possible rehabilitation, country like Singapore, China, Taiwan, Japan, Hong Kong. They got probably the best available of the neurorehabilitation. On the other hand, there are countries where not many neurorehab specialists or rehab specialists are there. Leave aside, there are countries where even in Asia where there are one or two physiotherapists over the country like uh, difficult to explain why it is there. Uh, so there is a diversity, good centers, not centers. Then there are different conditions. Asia is a country where stroke is growing now as compared to the West. Not only that, high incidence of traumatic brain injury and spinal cord injury, a large number of disability due to the neuroinfection, children, particularly the cerebral palsy. So these are the conditions which represent a huge number of neurological disability, and they require a different set of therapy program and expertise. So there is a challenge. Acute care is been slowly getting better and better, be it stroke, be it neurosurgery, be it in children. But then continue of care after the patient get discharged or the just before the discharge, going back to the home or to the neuro rehab centers is a big challenge. And this is not only for India, but all other low middle income country. And therefore, what we are looking in next decade is there's definite better awareness among the neurologists, therapists of the neurological issues which are available. There are definitely a lot of new concepts are coming. They are aware about it, and we are going to see a better and better neuro rehab care in the future. And we'll discuss further when you come back to me. So this is a prospect which I feel that we are passing through a phase where from zero rehabilitation, we have now come to a place where some rehabilitation has been going on. In certain countries, it has very good, but in other countries, we need to catch up and provide the basic rehabilitation services to all, and we all will have to work hard on to that. So that is a big challenge for all of us. Thank you.
Yeah, thank you, sir. Thank you for clearly laying out the present situation and the problem that we are facing, but also a hopeful future. Now, Dorcas, I would like to continue with the same thing. Now that we are looking something forward to a better future, better daily care for delivery, especially when it comes to physiotherapists. Uh, how do we, relatively, the number of physiotherapists in India is quite better compared to many other countries, like how Dr. Nirmal Surya said. How do you think that our evidence-based and context-specific research is shaping the future, and how can our institution can contribute more meaningfully for the global literature, because it's going to be from these literature and output that the new evidences arise, and what more we can do will be much clearer. What are your views on that?
Thank you, sir, for that very important question. Evidence-based and context-specific are very commonly used terms these days. And why it actually matters, thinking about policy, thinking about the national budget, I think we should be very clear about why using specific proven therapies are very important to show improvement, because health systems are being pushed to expand rehab as an essential service within the universal health coverage. That is what even World Rehab Alliance is working towards, advocacy for rehabilitation to be included as an essential health service. So when we think about what works for whom and at what cost, this is not just an academic question anymore. We have to look at it as a coverage and financing question as well, if we have to make it effective in countries where resources are already low. And I'll just give you an example of the one of the countries that we are working with from our institution is the country of Timor-Leste, Southeast Asian region, which has one stroke unit that we developed there with one physiotherapist for the whole country, which is around 60,000 population, which is, like Nirmal Surya sir said, it's really crazy. And in such a context that is so diverse that sir is talking about, apart from national budgets and evidence-based proven therapies that are being used, which is very important. We should also think of how this proven literature from the high income countries, does it actually suit these low resource settings, their culture, depending on the family caregiving patterns, the device availability, transport barriers. There is so much diversity where documents like the package of interventions for rehab by World Health Organization, it links interventions to workforce and equipment. All these things can make a lot of difference on ground, which has proven to make equity, bringing equity into picture for all people, irrespective of the geography, irrespective of their socioeconomic status. So having said that, what do we, I think the second part of your question, sir, was institutions like ours, what should we do to improve the literature? There is a lot. I think we have just stuck to simple trials. We have, most of us, even for our MPT or master's thesis, we have stuck to single center researches. But I think there's a lot more demand for running pragmatic multi center trials that are focused on implementation. There is no need to reinvent the wheel and start doing efficacy and effectiveness studies. There is literature there, but what happens on ground in low resource settings, implementation studies are required. I think we also need large minimum data sets. Like the PIR module gives us all these framework for describing intervention components. Using that, doing literature, improving the literature from low resource settings is very essential. Registries are essential. There is so much more that institutions in India can do.
Yeah, thank you, Dorcas. Thank you for pointing out about also how we don't have to rely on developing again new studies and rather focusing on implementation studies. Now that you pointed out about the package for interventions, I will continue with that to Nirmal Surya sir, because you have also been part of that. There has been quite a few, Dr. Nirmal Surya, Dr. Abhishek Srivastava, they've all been part of package of interventions developed by WHO, part of the WRA as well. And now that we have something, as I said, there is some rehab happening. But what changes that should happen at a policy level to ensure these could be implemented? So if we say one is implementation research, but we already know a few things that can work, how do we go about implementing it, and what policy change will help in ensuring implementation of such things? So can you unmute yourself, please?
Perfect. Yeah. Thank you. I think this is a very, very critical question, John. Now, country like all countries of LMIC, the focus is on acute care. The policies are framed around acute care. And nobody is really thinking about how to go beyond that. And ultimately, the burden falls on the family. And then there is a finance, which is a real critical, as the family has to spend money. You know that today the multidisciplinary team, so if a patient gets stroke, he has to undergo physio, OT, ST, cognitive therapy. It's impossible for even good rich people to afford that. And therefore, the first policy change has to come is government need to provide proper neuro rehabilitation setup across the country, which should be free of cost, multidisciplinary, at least for time during the hospital and maybe for a couple of weeks after the acute care has been done. So acute, post-acute care has to be covered. Then there has to be an insurance coverage. So it should be mandatory that all insurance should cover at least 6 months to 1 year post neurological insult. It should be part of the therapy to be covered. And I think these two are very, very important. Then government also has to work on providing the workforce. That means trained staff. Now, task shifting is something we have been talking about, and we're talking about WRA also, is so important. And therefore, whosoever is available has to take the lead to provide the whatever best neuro rehab. Therefore, that means we organization like IFNR, IAP, or the other organization, AOSNR, they need to develop the courses of minimum level of training or minimum possible therapeutic intervention which should be provided to the patient with neurodisability. So that could be for the caregiver, that could be for the family trainer, that could be for the nurses, because unfortunately countries like India and other LMIC, there are no neuro nurses or there are no rehab nurses, which is a very big workforce. If we can train these nurses who could work intermediary between the topmost therapist and the patient. So policy has to come to provide the workforce with minimum standard of care which can be taken, and we need to formulate that what do we mean when we're talking about minimum standard care, be it stroke, be it cerebral palsy, LD, spinal cord injury, or the traumatic brain injury. So there has to be a clear-cut scope. We need to develop more courses for caregivers as well as others. So these are some of the things which government has to understand, the private institute has to understand, and there can be a collaboration between organizations like IAP, IFNR, AOSNR, WFNR, who could be the key to provide these policies or provide these training courses, which could later on be taken by the government. I think these are some of the critical points which I personally feel can change the way the therapy can be given and outcome for the neurological disability can happen in the future.
Yeah, thank you, sir. Very well said. The support from the government side for the insurance, for the infrastructure, and also for the trained people as well. I will probably take from that point onwards to go to Dorcas. Dorcas, what do you think? What level of training what type of training do you think is needed at professional level for physiotherapists primarily to ensure at a bachelor level the basic definite curriculum framework that would ensure that we provide quality physiotherapists to uh, deliver good services to our patients.
So I think there are many more senior educators, much more senior than me. But then what I have noticed in the past 14 years of my teaching is that there has to be a very big shift among our graduates and postgraduates in understanding outcome-based rehab. They need to understand that there has to be some measure that they follow before and after to see differences. Something like this is not very common, and sadly, in many institutions in India. And this is not to put down any institution, but to raise the standards in any way possible. So this outcome-based rehab is non-negotiable. Everybody needs to understand that, and only when we understand that can we start thinking about which outcome works best for which neurological condition. So then the standardized outcomes, understanding of all that will be better. So one of that is that, sir. The other thing that I really that is very close to my heart is exposure of graduates itself to clinical practice guidelines, whatever is available out there for condition specific approach. So not many of our, I mean, I think, sir, you were involved in the study that we did, the reform study. Practicing clinicians as well as students are unaware currently of even things that like guidelines that do exist. And when we talk about context-specific guidelines, that is a next step further. So at least knowing the available guidelines for each condition, again, is a non-negotiable for graduates and postgraduates. And the third and last thing I would like to highlight here is I think right from the graduate levels, where I think in many institutions, neurological cases for physiotherapy, they start seeing them in third and final years of graduation, or maybe only in the final year. they need to start looking at it as a long-term process. So they need to start looking at it as a long-term process. So there has to be a facility in every teaching institution where they tie up with NGOs or community-based centers where students are able to see not just acute cases in their ICUs, but also long-term follow-ups and community-based involvement. So every institution needs to have at least these three things at the graduate level, is what I believe.
Yeah, well, thank you, Doctors, for that insightful thing. We just catch up again. There should be a good learning about the outcomes so that they have to implement and also see clinical practice guidelines and involvement of community level as well. So as we talked about community level, I'll go back to Nirmal Surya sir. Sir, I have always heard your talk on family-based rehabilitation. So when you when you go into say dealing with patients with neurological disorders in community, uh, what type of intervention you think would be more appropriate, and as future therapists should be prepared to deal with?
I think, when you have a large population, you have advantage. An advantage is that you can mobilize the people from the family. You know the family concept, and why I always keep on talking about the family centered or family based rehabilitation, because a country like India and Asia, they have a very close bonding between the families. And you know, when somebody get admitted in the hospital, uh, the challenge is how many relatives are going to come and see the patient, which is not there in the West. West, you hardly find anybody coming and seeing a patient admitted in the hospital, or at the most during the visiting hour, somebody close who are with the patient, they come. But here, even the relatives, the friends, the neighbors, the whole village sometimes come depending on the popularity of the person. So I realized that when family comes and everybody wants to know how is the condition of the patient, they only want to ask you the question. I rather thought from very beginning, this is I'm talking about 25, 30, 35 years of my practice. I said best way to get them engaged and not keep on asking you all the time question is involve them in the management of the patient. And they can't be involved in the medical management, but certainly they can be involved in the rehabilitation process. So they are the best person to do the movement of the limbs during the acute care, making the patient sit at the edge of bed and can sit next to the patient, helping the patient to take on once the therapist has taken on the wheelchair, to be there with the patient, putting into the music, talking to them, providing some cognitive and behavioral therapy. So what you are doing is you are doing two things. One, you are sensitize the relative for a long-term care of the patient. And second is you are keeping them busy. The patient is also sensitive to their relative, depending on whom he like or whom he don't like the touch and respond to them. So that's the way I thought, and the results were started coming better. So that is where, when you are having a city where not many relatives are there, you involve the family right from the day one, and you could see the result. But places like smaller town where the community is very again bonding, the whole village is one. This is where community-based rehabilitation comes in. But when you have a community, you need somebody train them how to lead them. Community cannot be just told them that do this therapy. There has to be some leader, some therapist who is expert, who can guide and give the proper guidance to the community that how they should be dealing with the neurodisability. So there are different challenges for both community, but in rural area, I strongly believe that community-based rehabilitation is something which can work, and uh, it can easily be guided under the leadership of the sarpanch or one of the leader of the village, whom if a therapist can get in touch, put them together and can take it forward and can get very, very good result. And in that, what happen is some of the NGOs will come forward. They'll provide you the social worker. So you could deal with large number of patients together. But in cities like metros where the challenge is there, smaller places, not big family, a family-based rehabilitation could be the solution. And you need to bridge between the two, depending on the, situation which you are dealing in particular area. So I feel that family-based rehabilitation and community-based rehabilitation has its own place, its own role. Both are exceedingly useful, and we should not close our eyes or ear on one part. We should keep it open and get forward to take care of the neurodisability at large, reaching out to everyone.
Thank you, sir. Thank you very much on your insight on that, and I truly agree with you. And it's really important to train people at the grassroots level to ensure that they are able to face it on their own. Now, as I move ahead with that point to Dr. Dorcas about now, one is to train people at the community level, and the other assistance that is coming from to a therapist right now is more through technology, use of telerehabilitation, robotics. How do you see the evolution of the technology in neurorehabilitation in reaching the patients or caregivers, and also in implementing a good rehabilitation program for these patients?
It's I think, again, a very relevant question for all physios, be it the purists that we call who do not really believe in telehealth and who think hands-on approach is the best, or for the other group who think that everything needs to be done. This is a very relevant question. The world is changing. We have Gen Zs coming in. We have Gen Z patients who are coming in. And even for the ones who are not Gen Zs, millennials and baby boomers and whoever, they also need to be reached. The matter here is about reaching those who need us. So, by hook or crook, whatever we have, we need to try. I know it may not be the best, like many of us think, tele-rehab, but in the past decade, there are beautiful virtual tools that are available, not just the immersive, fancy, large screen virtual reality tools, but also remotely used phone apps that are being contextualized, that are shown to improve functional outcomes. One of the best studies that we can read about, set in UK, of course, a high-income country, is a study by Stephen Kramer, who showed after a 4-week tele-rehab sessions, which was monitored regularly, the patients did show improvement in arm functions. And similar studies have been showing good feasibility, safety, and acceptability within India. So I think we can not turn our faces away from telerehabilitation. There are pretty low-cost sensors, pretty low-cost physical activity monitors that can be used. So far, we have the government has been kind to us with respect to data privacy. But if we work around that and make it more stringent to protect our patients, I think there's a lot of potential in using simple things like Zoom and WhatsApp applications to reach the unreached. And having said that, I also need to highlight the work of CMC Vellore, the Department of Bioengineering, and IIT Chennai, who have developed very low-cost robotics. And they have shown that it can be used in a home-based setting, led by the caregiver and the patients themselves. So there is a lot coming out here, but what is challenging right now is to show that it is useful in a large scale for nations to take it up as policy plans. That is the gap we still need to bridge, and design studies to work on that.
Thank you, Durkas. Thanks for that. And I think I'll take the technology part to Anil Mansuria, sir. So considering in a larger perspective, what do you think the technology would play a role in the future, and how the Asia Pacific region professionals, physiotherapists, all other interprofessionals should be ready for ensuring they are technology ready to implement programs?
John, there are two things which we want to highlight. The technology is going to be the future, but we cannot solely depend on technology. There has to be experts who are knowing where and when to use technology. Now, so many new gadgets are available. I was in a very small place day before yesterday, that is Tichandur, with a population of 50,000, uh, 40 kilometers away from the Tuticorin, where one of my mentee has opened a neuro rehab center. Now, will you believe that there he has RTMS, there he has uh, hand robots, there he has a swimming pool for aquatherapy, which is heated, body supported treadmill training, the Myro. You name the equipments, they are there along with his team. So there are technology which are going to available even in a smaller places, which I don't think those equipments in a single place are available at many tier 2, tier 3 cities. And even in metros, there are only few centers where this technology are there. But at the same time, in the big centers, the technology is being used just for making the money. That means people are put on the machine and nobody look at them otherwise. They're just put onto the machine. So the future, the challenge is going to be when to use the technology, who are the ideal patient to be used, and who's going to decide on this. This decision has to come from those experts who are the leaders, who are running the center, or the providing the neuro rehabilitation to this patient. And this is what is going to be a big challenge. So technology is going to come, be it low cost or be it high cost. And it will be more and more centers are going to open, because as people are realizing that there is a great demand of neuro disability to be treated by neuro rehab, more and more centers are going to come. The industry, the industry of these equipments, which were not very active 5 years ago, is now very active. You find that there are companies who have come into India now, who earlier used to have the distributor only. So they have also realized that potential India has got with large population and the paying capacity. So technology is going to be there. Question would be man versus machine. And how do we balance this man versus machine will depend on our own ethics, our own judicious thing, and how best we are treating. And there's no point in treating a patient who cannot afford with all this robotic. And there's no point if a therapist who is good enough can treat the patient without any of this technology and give the equal result. He better do those rather than going onto the technology. So yes, technology will be there. You need to know who are the patient. Of course, if a patient with complete paraplegia, spinal cord injury, he needs robotic locomotive, he has to be there because he cannot be made to stand and walk with the therapist and require many more people. So you have to take a decision. You have to decide. Equipments are there, when to use, how to use.
Great, sir. Very true. And as you said, choosing for the right patient and using it as an aid is what is going to be the right way to do it. Dorcas, would you like to add any other points to this and talk also about how we can ensure, as physiotherapists, you can ensure that the human touch is still there, even if you do use technology, and ensure, like sir said, we use it for the right people only.
Right, so I think this is what was running in my mind as well as Nirmal Surya was, sir was discussing a lot of things, which is very relevant. So our focus, I think, as neurophysiotherapists and all the listeners here for neuro rehabilitation is dose, the amount of rehab that we are providing. So it's not the gadgets that we're using, like sir has highlighted very rightly. the focus should be dosage, the amount and intensity of rehab that we are providing. So, dose over gadgets, dose over technology. Technology is just an aid. So, that would be the first point I'm trying to say. So, practicing of repetitions, either manually or with the tech, really doesn't matter as long as you hit that dosage that your patient requires. But beyond that, I think the other thing we need to remember is to keep the human touch. John sir, like you said, there are other different ways. I think a very good paper for us to understand and read is the one by Dr. Coralie English. This is focused on stroke rehab, of course, telehealth in stroke rehab, but it is applicable to other neurological conditions as well. She talks beautifully about different types of telerehabilitation where technology is being used remotely, asynchronous and synchronous, where the therapist is there live and assisting the patients. And there are ways in which you can do it. There are guidelines for this also in the world where you can use and do this in a systematic way. Outcomes also can be measured remotely through video calls, and there are resources that you can use as well, and we can share it with you as well. So that was the second thing. Remotely supervising by a professional qualified physiotherapist is very, very essential. And lastly, I think it's a mixture of all of this, hybrid session structures where there is in-person sessions if the patient can come to you once a week, and then followed by these tech enabled remotely supervised sessions, all need to be adapted by professionals like us. We cannot stick to the conventional life anymore of a physiotherapist. The world is changing, so we need to change with it.
Okay, thank you, Dorcas. So one last question, and I would like you to also end with your thoughts or what the therapist should do. But one thing I have always, from the time I met you more than a decade ago, you were very encouraging for all rehab professionals to come together as one team and work together, not in silos. And probably that's how the entire IFNR phenomenon was formed. And even today, in every IFNR conference, we have combined sessions, we have IAP sessions, IOTA sessions, and everyone else. So, how do you see as future neuro rehabilitation professionals, physiotherapists, and others should work, how they could work together to produce the best results for the patients and for the nation?
John, this is a very critical. We, as a human being, always think that we are the best and nobody can be better than us. But believe me, when I started the first neuro rehab OPD in 2000 at Nair Hospital and Topiwala Medical College, it was not even heard of. That was the first multidisciplinary OPD which I started in Mumbai. And what was beauty was that there would be a lecturer or professor from physiotherapy, occupational therapy, speech therapist, and neuropsychologist and neurologist. So all of them would be sitting in OPD all together. And we built up a 60 pages booklet where everybody has to evaluate the patient, irrespective whether patient had motor weakness, sensory weakness, speech is there or not there, cognition is there or not there. Even it is not there, they can write that cognitive patient is all right, or speech and swallowing assessment done, it is normal. And then I started, depending on their assessment, giving a program. In 2 years' time, everybody started realizing their deficiency, that what patient they were treating before and how the patient was improving, and now when they were interacting with each other, how the patient recovery was shaping and what they are learning. So OT people learning from physio learning from speech therapists, the neuropsychologists giving the tips that this is how I'm going to develop. And believe it, John and Dorcas, 2004, I started the tele rehab and family-based rehabilitation. Because when we realized that those patients who are very aggressive, abusing, nobody want to touch them. Physiotherapy don't want to touch, sir, he's hitting us. So what we started is we started making the video on the phone of the patient, giving them the exercise program, calling them that you do it at home and come after 1 month and bring what you are doing of that video and we'll correct them. And this is how the base of family-based rehab and tele-rehab which we started. And I think we have been continuing that over a period of time. And even in the rural area, in the camps, when we are treating with disability, with epilepsy, we have been doing it. But what I'm trying to say is when we started working together, the better number of papers, the better, and patients were doing so well that everybody was excited. And then they came together and it became a team. So that is together, everyone achieved more. And that's how it took me 10 years from 2000 to 2010 when I could do first multidisciplinary meeting in Goa. I think some of you were there at that time in, neurology and rehabilitation in 2010 in Goa. And that's where the everybody said, sir, we need to come together and make the organization. And that's how we made the Indian Federation of Neuro Rehab. And that's from there we have taken together. We are growing together. Where we were lacking in past couple of years is not working together with low-cost technology for the IIT guys, the engineer guys. And last 3 or 4 years, we have been really working. IFNR is working with IIT Gandhinagar, IIT Kanpur, IIT Indore, and we are really coming out with some good low-cost technology for the neuro rehab. And we are encouraging them because, I have been invited for the past couple of years into the IITs, the engineers, and I tell them that you make a product and you think it is worst of the product. But as a consultant, I have 20 deficiency in your product. I would say this cannot be given to my patient. This is bulky. This has got this disadvantage. So you change as per my suggestion. But when I tell the therapists say it is not very friendly to be used on the patient and it has got so many things. So therapists rejected that what you thought is the best, what I thought it will be good, but yet it was not good. And then when therapist suggested and you change it and it given to the patient use only for once and then did not use because he find it very unfriendly. So we need to come together, engineers, therapists, the consultant, and the patient. Unless all these four people come together, you cannot have the best product which could be used more frequently, can be best. So I think that same way, when we all work together, whether it is physio or OT or ST, psychologist, orthotic, neurosurgeon, the urologist, who is at the advantage? The patient is at advantage, and we also learn from each other. We started knowing our boundaries. That's something which we were not knowing earlier, and now we are learning. So I think this is the concept of multidisciplinary team, and I think we, at least in neurology, we need to adapt that. I'm not sure about other branches of the medicine where you could do a solo therapy, but at least for neurology, it has to be multidisciplinary. And you find that your prospects change. You learn so many new things yourself. And the future is expanding. The brain-computer interface, which is going to change completely how we are dealing with some of the most difficult patients, be it the vision loss, be it the hand loss or hand robot, or communication or the cognitive. You will find that in next 10 years of time, these gadgets will come, but it is up to us in whom we use it and how best we use it. So you young therapists have got a big challenge. You got a lot of new things coming. You have to choose which path you have to take, and on that path, stick to it and do the research, do the hard work, and wherever you find difficulty, you have experts like John, Dorcas, myself available to guide you to give the best and make your career as one of the leader. Thank you.
Thank you so much, sir. Thank you very much. That was a wonderful way to summarize the entire aspect as well, sir. Now, Dorcas, your final thoughts or your words for the future neurophysiotherapist, what they should be looking forward to.
Thank you, sir. So, as a physio myself, who's practiced in India all my life, I think, like I said before, there are a few non-negotiables to improve our standards for ourselves. It is not a comparison with the world outside. It is not about the technology that's available in Japan or South Korea and China, the amazing products that they bring. It's not a comparison. As an Indian neurophysiotherapist, to reach the population that are unreached, one of the non-negotiables is for us to understand, like I said before, outcome-based rehabilitation in neurological conditions, and designing for scale from day one. From day one itself, you need to see where do you want to scale this rehabilitation plan for this particular patient, and that has to be there in our minds right from day one. um, I think, and like Nirmal Surya sir said, not just in our research, but in our clinical practice as well, there has to be a co-design approach. This practice of including survivors and their caregivers in our decision making, in our research designs, is something new in India, and think we should start looking at it more seriously. And training caregivers as co-therapists while maintaining professional and ethical boundaries is something that we really need to change. And it's not just providing them a sheet of exercises, this is what you do at home, but to involve them as co-therapists, as therapist aides, making it aphasia friendly, having multilingual assistance that you can provide, and culturally relevant things is something that we have to think about. And lastly, I think all physios, we should not shy away from discussions about policy. Our work has to influence policy at some level. So no matter what questions you have, we have amazing neurologists and senior leaders here. Go ahead, ask them questions, ask them the tough questions. Yes, I see questions about pay parity. I see questions about what is the future, what next for physios. I think hard questions need to be asked in a multidisciplinary environment, and we should not shy away from it.
Thank you, Dr. Thank you for your points. I think both of you have covered almost most of the major aspect related to the neurorehabilitation, and especially specific to some of the points related to the neurophysiotherapist in the West Asia Pacific region. Now I hand over the session to Dr. Dharam Pandey so that he can ask some of the questions that are asked by the participants to the panelists. Over to you, Dr. Dharam.
Thank you, Dr. John. And I'm really excited and to see that the great discussion was going on, and I was listening very, very carefully as Surya sir all very rightly mentioned that there is a very urgent need for policy change, particularly for insurance coverage, and government has to work towards development of government sector neurorehabilitation centers and all that. So there are a few questions. First, I'll take the most relevant one. There are so many questions from audience. So there is a one person is asking that in many regions, sir, especially in rural and semi-urban areas, there is a shortage of trained neurophysiotherapists and rehabilitation staff, as you also mentioned that in your comment, and very limited infrastructure. So, in your view, how can these gaps be filled, and what is your recommendation towards government collaboration, or if any NGO is listening this conversation? So, how we can strengthen the infrastructure in rural and semi-urban area, and how we can improve the workforce in these areas?
I know the trained therapists are not available in the rural area. I know even the neurologists are not there at many district and sub-district places across the country. There are particular states in India where things are very bad because number of trained people are much less. I think it will have to be dealt with couple of points. It cannot be sorted out in 1 day, 2 days.
Yeah.
On one side, you have a community-based rehabilitation which has to be worked on. There are NGOs who has to work into those rural area to provide the best possible thing. That's one part. Everything will not work at everywhere. So the second aspect is those patients who come to the urban or semi-urban area and are going back, they are the one who has to be treated under the banner of tele-rehabilitation and the family-based rehabilitation, as I mentioned. So we need to have a hub and spoke pattern. The urban or semi-urban area is the one after the discharge, provide them tele-rehabilitation with the coverage of the family. So the family is being trained right from the beginning, and then they are periodically, as Jorkas also mentioned, once in a 15 days, once in a month to be supervised what they are doing. Number three, those who can afford certain technology, they are available, which can be given. So now we have a couple of things like hand gloves, things like certain robotic as Valor has developed. They can be given to the patient through the iCloud. They can be monitored and the patient follow-up can be monitored. So for 1 month, 2 months on the rent can be given. So the policy to cover the rural area is not just one way. It has to be multi-pronged, community-based rehabilitation, family-based rehabilitation and tele-rehabilitation, and low-cost robotic, providing them at home, and at the same time, working out with the government. And government is very sensitive now. At least at every district hospital, there is a physiotherapist, there is a speech therapist, and there is an occupational therapist. So taking the, motivating them to treat this patient and helping them to learn how to treat them could be another solution which we need to look at. And I think you guys, all those who are here or those who are listening, they have a great opportunity, because the next second tele-neuro-rehabilitation, international tele-neuro-rehabilitation meeting is going to held in Mumbai. And there are going to be nearly 40 to 50 international experts who are going to be there. So you have an opportunity. If you are working, and I know that there are more than 60% physiotherapists today after the COVID has been using some form of other of the tele-rehabilitation.
Yes.
It is good that they can come there and discuss with these experts that how best they can further take it without getting any data challenge, any ethical or legal issue, and do the research same time while they are providing the therapy to these patients, and create a module. If they are experts and they are doing it for many cases, create a module which can be used by the other. So there is a great opportunity for all of you. 9 to 12th April in Mumbai, International Second Tele-Neuro Rehab meeting. All international experts who have been doing tele-rehab would be part of it. Great opportunity for you even to show your work and learn from them and take it forward in this country.
Thank you, sir. Thank you very well. And definitely we have opportunity, and I'm coming there. I have the paper selected there and
Thank you.
tele-rehabilitation. So we'll meet you there, and definitely everyone has a great opportunity to uh, make that. And another question, Dr. Lucas, I'll come to you. You were talking about the guidelines and the things, context-based specific guidelines, all those. So, Nista Chawla is asking, I'm curious about how a context-specific intervention guideline uh, hold up when scaled beyond ideal condition. How we can make it scalable?
Thank you, sir, for that question. Nistara, hi, I'm glad you asked this question. We've worked together before, but I'd like to remind all of us again that guidelines are a certain document, but apart from that, there are protocols, clinical protocols as well. So when we talk about scaling them up, clinical practice guidelines can only give you a structure, each of us a structure of how things are to be done. But what exactly is to be done in different contexts with the same clinical practice guideline is something that protocols can give you, which is not developed for every domain of rehabilitation.
Yeah.
So that is one primary difference we need to understand. The second thing I'd like to highlight is this is where implementation studies come into picture, and low resource countries like India, Nistara, need to work towards pragmatic multi-center implementation studies to show that these context-specific guidelines do work. Because we have effectiveness results, we need to show the implementation results of it in low resource settings. Yes, Dharam sir, I think that those would be my two key points.
Another question. I'll go to you only about there are often disconnect between academia and clinical neurophysiotherapy training. Like the real world is something different than the academia. So how can we better integrate the faculty and clinical neurophysiotherapists to ensure the training what the neurophysiotherapists are undergoing reflect on a real world current practice trend? So can you highlight that on some point on that?
Yes, once again, I really like to highlight that I only have 14 years of teaching experience. I think senior educators would be able to tell better. But in my limited experience, I really think, be it practicing clinicians or graduates and postgraduates, they need exposure. Case load exposure, case presentations, and not just history taking. They need to do assessments. They need to do the various approaches, hands-on practice on an everyday basis. There has to be enough amount of case quotas that they present. This is what used to happen back when we were students. We had to present enough number of cases to get marks or whatever the credits that you follow. So I think this kind of system can also be started like in other countries for practicing clinicians as well. I think this may not be acceptable by many, but many countries do follow peer review based licensing exams, updating the licenses that India doesn't follow. Something like this may help us keep ourselves updated on the new clinical evidence that's coming up. I really feel that would improve the quality of practicing clinicians as well, and not have that divide between academics. So not just keep publishing papers, but also have those exams routinely, like 15 years of physiotherapy practice, and then we are practicing 15-year-old evidence.
Yeah.
Doesn't really make sense. Yeah.
Yes, and you rightly earlier also mentioned that the clinical posting has to be started earlier in graduate level, so they get better exposure to real world clinical scenario. Dr. Suresh, our question for you
I just
there
want to
is,
add something in this,
yes,
that
yes, sir.
IFNR has taken a great lead to start the fellowship in neurorehabilitation.
Yes.
And the first course is starting from 1st of April at Pacific University in Udaipur. IFNR has now, this is open for physio, OT and ST. It's a 1-year course, complete comprehensive neurorehabilitation fellowship. And IFNR is collaborating with 2 other centers to start this fellowship. The idea is to provide the standard of care across the country. So at the Abbas, Delhi is another place where we are going to have this fellowship, and third will be Sri Ramchandra Institute in Madras. So these are the 2 more places where next year our fellowship will run. So those who are really want to go into the neurorehabilitation advance after their finishing the MPT, they are most welcome to write to us, and they have got a great opportunity to make themselves to the polished neuro rehab specialists, particularly with the fellowship in the future.
That's really great, sir. And everyone has a great opportunity to learn. The only last question for you is that regarding research, as a very, very senior person in neuro rehab, and what topic will you suggest to young neurophysio to focus on, particular to neuro rehabilitation? Any suggestion?
So if you look at the research from the point of view of India in the neuro rehabilitation, there's a huge scope. They can decide whatever is their interest. So if somebody is in the pediatric, there are so many things they can do, right from the pediatric stroke to the cerebral palsy, to the learning disability, to the global motor regression. They've got many opportunities. It's up to them that which path they have to take and how they want to do it. If it comes to the adult, you have multiple choices. Stroke is something many people are working, because a number of India has stroke, but there are hardly people working in traumatic brain injury, which is as much as a stroke or even more than stroke.
Yes.
And these are the younger patients.
Yeah.
There's a greater opportunity for them to get better because of neuroplasticity. So you have got lot of potential, starting from the cognitive to the motor to the sensory to the psychosocial rehabilitation in the TBI. So is the spinal cord injury. That is the most challenging. But if somebody decide to do the spinal cord injury, there are a lot of new things are coming, exoskeletal, robotics, and so and so and so on, which they can choose and can come out with newer technologies. So is movement disorder, Parkinson disease. It's another one where, there are multiple potential of the research, right from the music therapy to the dance therapy to the gait. And the gait lab itself is a very big thing.
Yeah.
If you have a gait lab, you can do so many research in different part of, including simple things like neck pain, back pain, postural correction, the way we have been handling the carpal tunnel, the hand movement. So all that from simple to complex. The big
Mm.
opportunity in India is up to you. Which field you
Mm.
want to go? What is your interest? Where you want to put your reading, learning, Google, Cochrane will
Yeah.
take the thing, and who is your guide who can guide you to take it forward.
Yes, very rightly, sir. You said, sir. Because when we talk neurorehabilitation, sometimes we very limit ourselves to stroke, spinal cord injury, TBI. That's all. But there is a lot of beyond that. There is a lot of other neurological impairments that we can work upon. So, with that notes, thank you very much, all of you, and for such a nice, engaging discussion. So, Dr. Neha, over to you if you can have something to say.
Yes, thank you so much, sir. It was a wonderful expert talk with all the question and answer session taken. So we thank you for joining us today for this evening. And Nirmal Surya, sir, may I request you to tell about the recent conference which is going to come up? I'll just share the slide about the same. Thank you, sir.
Yeah. So early bird has been closed, but if you come with a group, this is a well-designed conference for all of you, and John, Dorcas, all are part of it. There are 10 workshops which will happen right from aquatherapy to botulinum toxin to motor rehab, hyperbaric oxygen, neuromodulation. We'll have hands-on on RTMS, NMT, that is the neuromusical therapy, and some of you have already done the courses. Pediatric rehabilitation, full day, robotic rehab. We are going to have experts from Korea and other part, UK, sensory rehab, speech and language, tele rehab is one full day, and the experts from World Tele Rehab special interest group would be there. And then something which is very interesting, and many of you will find, ultrasound guided pain intervention and nerve releases and nerve block, which is something new again coming, and vestibular rehabilitation. So many of you may be interested in vestibular. So you could choose which workshop you have to take. And then there are 3 days of continuous sessions. There are special session by IAP, there's special session of IOTA, speech and language therapists, AIPMR, and other IAN. So all that organization are having separate sessions. There's just one parallel line going on for the tele-neuro rehabilitation. Nearly, as I mentioned to you, 40 to 50 international speakers will be there. There's a parallel Lancet Commission meeting is going to happen. So that is something those experts, and there will be a session on a Lancet Commission. So you could also be those who are really into the research. Uh, John, Dorcas are part of it, and I'm also part of it. They can be there. There will be 90-minute session between the Lancet Commission in Neuro Rehab Chair, John uh, Mayowa Ovlambi and Thomas Platts, who would be interacting and giving the insight on how we are going to develop the neuro rehab guideline. So multiple choices, your interest, you can choose and stick to that. And your interest, you can build it further with your research, present your paper. The late breaking abstract will start on 15th of January till 30th January. So you have an opportunity. And if you are in a group, you can come out with a group of 10 or more and then can write to me. We will see that you get early bird registration, which is already closed. So I think something you cannot miss in today's, because this is a very big opportunity of international meeting. Thank you very much.
Thank you so much, sir. Now, moving ahead, I would just very shortly present the details about this upcoming conference of Asia Western Pacific Regional Conference of 2026. That Indian Association of Physiotherapists is going to be hosting this, and this conference is going to take place at the Yashobhoomi Convention Center, New Delhi, in the month of September 2026, and the dates are 26th and 27th of September. So allow me to have this short presentation with all of you. The conference links has been sent to the chat group that we are onto this meeting. I'm just going to go ahead with very briefly, quickly with the conference presentation. Is my screen visible to all of you?
Yes.
Yes, sir. Thank you. So this World Physiotherapy Asia West Pacific Regional Conference, and proudly IAP is going to be the host for this conference, for this regional conference. And IAP is one of the oldest and largest professional membership body of physiotherapists in India. And there are few key initiatives by IAP, that is IAP Suraksha scheme, that has a cover of around 10 lakh rupee for the physiotherapist registered under it. And also there are different research grants for its member. And upon that, there are also sub-specialty groups of IAP for specialization and professional clusters, which enhances the profession segmentation and capability. Like neurology is one of the subgroup of IAP. Also, there are clinical practice guidelines textbook, which has been released in the last few conferences on geriatrics, women health, and stroke rehabilitation. For IAP, we have our national president, Dr. Sanjeev Jha sir, who is leading the entire team of physiotherapists, and Dr. Vruchi Varshney ma'am is the treasurer of IAP. And for this conference of AWP, ma'am is the organizing secretary as well. And also she is the national head of Indian Association of Physiotherapists, Women Cell. Now, about this World Physiotherapy, it's a global professional organization that represents the physiotherapists around the world. And it was founded in the year 1951 as the World Confederation for Physical Therapy. And later it was rebranded as World Physiotherapy. So it unites the physiotherapy professionals globally, promotes high standards of practice, education and research, and facilitates the knowledge exchange. And the Asia Western Pacific region for World's Physiotherapy is one of the 5 global regions under this entire umbrella, which comprises of 32 member organizations, which is spread across the Middle East, through Asia and to the Pacific region. To chair this entire regional executive committee, we have with us Dr. Marco Pang sir. And from India, we have Dr. Nehal Shah ma'am, who is the vice chair and represents India for this AWP region executive committee. And she's also the member of Indian Association of Physiotherapists. And as India is a proud host for this AWP regional conference, theme for this year of 2026 Congress is going to be about fitness for all, empowering communities, building inclusive health. And upon this, let us just have a look on this short video about the convention center where this conference is going to be held. Is the audio available, or the volume is available of this last video that we are playing?
Yes.
Yes. Thank you.
आज यशोभूमि के रूप में साकार हो चुकी है। 221 एकड़ क्षेत्रफल में विकसित, अत्याधुनिक सुविधाओं से सुसज्जित यशोभूमि दुनिया के सबसे बड़े मीटिंग्स, कन्वेंशंस और एग्जीबिशंस की सुविधा से युक्त केंद्र में से एक है। यशोभूमि इंटीग्रेटेड डिजाइन का मास्टरपीस है। इसके केंद्र में आइकॉनिक कन्वेंशन सेंटर है, जिसमें अलग अलग आकार के 15 कन्वेंशन रूम कुल 11,000 प्रतिनिधियों की मेजबानी आसानी से कर सकते हैं। प्राइमरी ऑडिटोरियम में इनोवेटिव ऑटोमेटेड रिट्रैक्टेबल और रिकॉन्फ़िगरेबल सीटिंग सिस्टम लगा हुआ है, जिसकी मदद से 10 अलग अलग तरीकों से बैठने की व्यवस्था की जा सकती है और एक बार में 6,000 गेस्ट बैठ सकते हैं। कन्वेंशन सेंटर में विभिन्न कार्यक्रमों के लिए अलग अलग कमरे हैं। ग्रैंड बॉलरूम में 2,500 लोग बैठ सकते हैं। यशोभूमि में है विश्व के कुछ सबसे बड़े प्रदर्शनी हॉल। ये हॉल 28,000 वर्ग मीटर से 32,000 वर्ग मीटर आकार के हैं, यानी हर हॉल 5 फुटबॉल मैदानों के बराबर है। इस कन्वेंशन सेंटर में भारत का सबसे बड़ा एलईडी मीडिया फसाड है। तेजी से विकसित होते भारत की इस गतिमान विकास यात्रा में यशोभूमि निश्चय ही एक निर्णायक भूमिका निभाएगी।
So that was the convention center where this conference is going to be held in the month of September 2026. And these are a few glimpses of AWP regional conference held in the year 2024, which was held at Bali, Indonesia, with the theme of collaboration and transformation towards sustainable physiotherapy practice. So participants were there from across 31 countries and different territories. And also, this is the glimpse of the World Physiotherapy Congress that was held in the last year, 2025 in Tokyo. And there were good amount of networking and business opportunities at this World Congress. So now letting to you know about very shortly about the scientific events that is going to happen and take place at this regional conference. There would be workshops, pre and post conferences. There would be keynote lectures, panel discussions, interactive sessions, research presentations, clinical therapy, and quiz and cultural competitions as well. So the call for the speakers, the last date has been extended and it is valid till 11th of January 2026. Previously, it was till 31st of December and it has been extended till 11th of January. And for the abstracts, the date is going to be open till 30th of April 2026, and registration to the conference is mandatory for the application for the abstracts and for the call of speakers or speaker proposal. And there is this brainstorm-based sessions which is going to be happening there. Physiotherapy students, the practicing clinicians, physiotherapists, researchers, educators, anybody can be a part, and who thinks that there is a thought to be shared, definitely you should be a part at this brainstorm-based sessions. And the cultural events, there would be group dance competitions, fashion show, flash mob, global parade, and many more under this umbrella of cultural events. So there is going to be this online competition first at the state level. And after every filtration, these would be taken up at the national level and then would be represented at the final day of the conference internationally. And there is this student forum events that consists of the Physio Slam, Think Tank, Extempore, AdMate shows, Youth Parliament, PhysioFit challenges, and online reel competitions. So this conference, as you join in, this event is going to be uniting the physiotherapy professionals across the Asia Western Pacific region. This is one of the prestigious conference which is going to take place in New Delhi, which offers unparalleled platform for the knowledge exchange and innovation and collaboration. So this is going to be really a very good experience for all of us being there. And regarding the registration, as we see, there are different cost-effective things which happens at international conferences, state level and national level conference. So keeping that in mind, the registration fees at AWP has been kept very moderately for the students, for the IAP professionals, and for the people who are non-members of IAP as well. And there are different guidelines and deadlines also for the registration. And why this conference? Because it is going to be at the international platform. You will be able to network globally and with a good cost of a low registration fees that we may consider it as. And there is a good chance of for the collaboration opportunities. You will be having access to the global technologies, because there is going to be this health expo hall where all the exhibitors are going to be there, which is going to be presenting there, and you will be able to have a look and receive good things at this global technological hall. Along with that, participation in this international high value conference of with a very national conference registration fees is what that we can say. And the early bird registration has been extended from 31st of December. It is going to be open till 11th of January. So the slab is of early bird registration is still open for the students, IAP members, non-IAP members. And we also have this WhatsApp AWP regional conference channel where all the updates are available. So if you may scan this QR code and join the WhatsApp channel for receiving this updates of AWP. So these are the different details that we wished and we wanted to let you know so that you get sensitized regarding this conference. Thank you so much for allowing me to have this short presentation. Over to you, sir.
Thank you, Dr. Neha. Thank you very much for, and this is really a very right chance everyone to join there, because when you go to an international conference, you spend lakhs of rupees for air tickets, staying, and so many things. So it is for us, it is very great opportunity to have a World Congress here. It is representing Asia World First Week, and hardly you will spend thousands of rupees, some thousands of rupees, to have such nice conference access. So please go ahead, register that. And with this note, I really be grateful to Nirmal Surya sir, Dr. Dorcas, Dr. John, for joining us, and thank you very much for our senior leadership, IAP, for having me in neurology subgroup. And thank you very much, Dr. Neha, for facilitating this session. Okay, so thank you, sir. Thank you, Dr. Lucas. Thank you, everyone. And thank you, Surya, sir. And I'll be joining you in Mumbai soon. Thank you very much.
Look forward to many of you.
Sure. Yeah, thank you very much, sir. Thank you. Thank you, everyone. Thank you.
Goodbye.
All right.
Good night.
So thank you.
Good night. Good night.
Good night. Good evening.